All right, good afternoon, everyone. Thank you for joining our multimodality imaging conference. We're going to be discussing mitral regurgitation. I'll start by discussing the evaluation by echo, and Dr. El-Tallawi, we will review the role of cardiac MRI. So I'm echo first person, but will definitely explain why CMR is important in evaluation of mitral regurgitation. I'm going to start by this example of a patient who presented for a transthoracic echocardiogram, and I want you to guess how severe this mitral regurgitation is based on this view. Any takers? I'm giving you the color Doppler. Is this mild, moderate, or severe?
Severe.
Why do you say so? Are you able to see all of that? So if you're reading this echo, you'll write the report saying this is severe mitral regurgitation.
Not from this view.
Exactly. The right answer is always give me more views. Okay? Very good. So we do see that there's mitral regurgitation. You can see that there's probably some pathology of that posterior leaflet. There's color Doppler, but it's really hard to assess MR severity using, this view. But the color Doppler is not very impressive, but we can see that it's an eccentric jet. So we always need more views. Never make an assessment based on one view, especially in mitral regurgitation. So I'm going to give you the apical views. And what do you think here? Is this mild, moderate, or severe based on the color Doppler? Mild to moderate, okay. Maybe mildly enlarged. Mm-hmm. Okay. Again, it's the color Doppler is not very impressive. You could see that it's probably directed, anteriorly. So how would you read this echo? Mild, moderate, or severe? More views. Okay. So this is just to kind of prove a point that MR evaluation is not straightforward. And it's okay not to be able to tell how severe the lesion is just by looking at color Doppler. And that's why we're going to talk about other ways you can quantify mitral regurgitation severity. Never only rely on your color Doppler, especially if the jet is not well visualized. So this is the patient, and this is the TEE. 1 second. How severe is this MR? That's severe. See how impressive the Doppler, the color Doppler is. So sometimes we can miss these jets if you're just looking at your TTE and only looking at the color Doppler. So this is the point I wanted to make. When you're reading an echo, my approach is you want to make sure that there's no MR, so you want to rule it out in your mind rather than kind of rule it in. So when you look at an echo and you see some color, look at other parameters to prove to yourself that the MR is not significant. And this way you will not miss MR. Always imagine that MR is hiding and you just have to catch it or find it, okay? And again, this is another view showing that flail, posterior leaflet, P3 flail, and severe mitral regurgitation. So the point is never rely on one view, never rely on colored Doppler only. Look for other signs to evaluate your MR severity. So the approach to MR evaluation starts with defining the mechanism, determining the severity, incorporating multiple parameters, evaluate for the consequences of these lesions, and finally timing of the management based on your imaging findings. We're going to refer to the ASE guidelines for the non-invasive evaluation of native valvular regurgitation. So first of all, it's important to remember the different components of the mitral valve. It's a very complex valve. That's why I like it. It's not just the leaflets and the annulus. So you have your leaflets, the anterior and the posterior. You have the annulus. You have the cords. You have the papillary muscle. And then any LA dilation or LV dilation can also affect the function of your mitral valve. So remember, it's a complex system, and don't just limit your evaluation to the leaflet pathology. MR etiology is broadly defined as primary versus secondary. And primary is divided into either type 1, where you have leaflet perforation or cleft, type 2, where you have excessive leaflet motion secondary to prolapse, type 3A, which is caused by restricted leaflet motion in systole and diastole, such as in rheumatic valve disease, MAC, and drug-induced MR, and type 2B, where you have restricted motion in systole. Secondary MR is, again, divided usually either into atrial MR versus ventricular MR. And ventricular MR can be either due to non-ischemic cardiomyopathy versus ischemic cardiomyopathy. And the mitral world is a really 3D world. This is one of the 3D surgical views of the mitral valve, and that kind of shows you the different scallops of the mitral valve in relation to neighboring anatomical structures. So when you're looking at the 3D image, your aortic valve will be closest to your anterior leaflet. Your appendage, where you see a Watchman device over there, is your lateral aspect. Your interatrial septum is your medial aspect, and then you have the posterior leaflet. Those scallops closest to the septum are A3 and P3, and those closest to the appendage are A1, P1. And these are some 3DT examples showing how we can use 3D to localize the site of pathology. So the first image, you have an A2 flail. This is where you have an A2 prolapse. So P2 flail, A2 prolapse, and this is an A3 flail. This is an example of a mitral valve cleft in the anterior leaflet right here. And the reason this is important is a lot of times if you're looking at echoes and you're unable to determine the mechanism of mitral regurgitation, you don't see clear prolapse or flail, there's no evidence of LV dilation or dysfunction or LA dilation, think about mitral valve clefts because they can be easily missed by TTE. So you can see them by TE or MRI. This is an example of bileaflet prolapse. So you see that there's a prolapse of both the anterior and the posterior leaflets. And you always want to rely on your peristernal lung axis views when you're evaluating for mitral valve prolapse. And then if you do your color Doppler here, you can see that this is a kind of a mid to late systolic MR jet. So in addition to looking at your mechanism of mitral regurgitation, you want to evaluate the timing of regurgitation, as this can influence your quantitation. This is a TTE, again showing Barlow's disease, where you have bileaflet prolapse with significant MR that is anteriorly directed. So these are examples of primary MR. Again, when you're writing your report, you want to mention the mechanism and the severity and look for the consequences. So if you're looking at an echo and you can clearly see it's severe, but you're unable to determine the mechanism, this is not enough. We need to do further steps to evaluate the exact mechanism because the management can differ. This is an example of a fibroelastic deficiency leading to a focal flail. So this is a posterior leaflet flail with a wide flail gap, as you can see here, with an anteriorly directed jet. This patient had a mitral clip, and we placed 2 clips in that in A2 and P3, and that resulted in mild residual regurgitation. Other causes of MR that might not be as common include carcinoid heart disease, where you have endocardial plaques affecting the mitral valve and causing thickening, and left-sided disease can be involved in 5 to 10% of the cases. Radiation-induced mitral valve disease is common in patients who've had radiation to the chest, and you notably see that there's significant thickening and calcification of the aortic valve, the mitral annular fibrosa, in addition to the anterior mitral valve leaflet. Parachute mitral valve is also another variant of primary MR, where you have both leaflets attached to one papillary muscle. So just be cognizant there are different phenotypes of primary MR, and it's important for you to diagnose which one your patients have. Functional MR is divided into secondary mitral regurgitation, meaning ventricular functional MR, versus atrial functional MR. And the ventricular functional MR is related to either ischemic or non-ischemic cardiomyopathy, where you have LV dilation and dyskinesia, papillary muscle displacement or dysynchrony, and annular dilation. So this leads to tethering of the leaflets, leading to coaptation gaps or malcoaptation of the leaflets, leading to usually eccentric jets. In contrast, atrial functional mitral regurgitation is related to annular dilation and flattening. There's insufficient leaflet growth and fibrotic leaflet thickening, and this leads to altered atrial and annular dynamics. So when do we see atrial functional MR, which is an entity that has recently gained much attention? It's present in 6 to 7% in lone AFib and up to 53% in HFpEF patients. While we know how to manage, ventricular functional mitral regurgitation, we know the role of guideline-directed medical therapy, resynchronization, and transcatheter edge-to-edge repair. We still don't have much data about the management of atrial functional MR, but we tend to do the same things. Address the AFib, the HFpEF, optimize the medical management, diuretics as indicated, restore normal sinus rhythm when possible, and then potentially evaluate them for interventions. But these have not made it to the guidelines yet. This is a TE showing severe functional mitral regurgitation. So you can see that the LV is dilated and depressed in function. You have malcoaptation of the leaflets. Those leaflets are tethered, and you can see that there's a central malcoaptation gap with severe functional MR. And if you look at the 3D, again, you see that the leaflets are tethered, and there's kind of a central area of malcoaptation. This patient was treated with 3 mitral clips in the A2-P2 region with mild to moderate residual mitral regurgitation. Papillary muscle rupture is another cause of mitral regurgitation. You see it in patients with late presentation from STEMIs. We saw these more frequently during the COVID times when patients were hesitant to come to the hospital. So you have the anterolateral papillary muscle has a dual supply from the LAD and the circ versus the posteromedial, which is supplied by the PDA. So this is more likely to rupture. And management when you have a papillary muscle rupture leading to significant MR is surgical. All right, shifting gears and talking about the evaluation of MR severity. So one, you've determined your mechanism. And again, if you're unable to determine the mechanism by TTE, then you can always resort to TEE or MRI. So the color Doppler parameters that are used to evaluate mitral regurgitation include the regurgitant jet area. And there are physiological factors that actually influence this area, including the transvalvular pressure gradient, the phenomenon of entrainment, and the Coanda effect, which we're going to talk about. Entrainment basically depends on the driving force of your jet. So in the cases of high blood pressure, more RBCs are kind of recruited into the jet, and this makes the jet look bigger than it actually is. The Coanda effect, or when you have wall-hugging jets, basically relies on the principle that when a fluid jet is attracted to a nearby surface, friction will slow down your velocity, and when you slow down the velocity, remember color Doppler is a velocity map, then the color jet will appear smaller than what you would expect of a central jet. So if you see an eccentric wall-hugging jet, your color Doppler, just looking at your color Doppler, will underestimate MR if you're only relying on your color Doppler. So always make sure that you're looking at other parameters when you see wall-hugging jets, as in this case. Vena contracta is another measurement that you can use in your peristernal lung axis views, and you can measure the narrowest point of that jet to determine how severe your mitral regurgitation is. PISA is useful when you're able to see it clearly and when you're able to measure it, especially in primary mitral regurgitation. And the concept relies on looking at the area of proximal flow convergence. You can calculate your regurgitant flow by using the radius of the PISA. And so you have your 2 pi r squared times the aliasing velocity. And then to get your effective regurgitant orifice area, you would divide your regurgitant volume by your peak MR jet velocity. And to get your regurgitant volume, then you multiply your EROA by the TVI of the regurgitant jet. So using PISA, if you have a good one that you're able to measure, you can get your regurgitant volume and you can get your EROA. Before I move on to other methods, always remember that each method in quantitation of MR has its strengths and limitations. And one of the arts of reading an echo is determining when to use which method. That's why MR evaluation is interesting. It's not just looking for a peak velocity like we do with AS. You have to kind of think about it, look at different views, look at indirect signs of MR severity, and then decide which quantitation method you're going to use. Limitations of the PISA method is that it's not applicable in multiple jets. You can't just go around and add up all these little PISAs together. It's less reliable in eccentric jets, and it assumes a circular or hemispheric regurgitant orifice. Small errors in measurement can lead to substantial errors in the EROA measurement because you're relying on that radius that you're calculating. And the maximal PISA might not always coincide with your Vmax of your MR jet. So if because you're using your peak velocity of the MR jet to calculate your regurgitant volume, so if that's not coinciding with your PISA, then that leads to inaccuracies in the evaluation. When you look at primary and secondary MR, and you look at the shape of that orifice, then you notice that in patients with functional MR, your regurgitant orifice is more elliptical compared to primary MR. So you can see it here versus here. So sometimes when you're using PISA in evaluation of functional MR, this can underestimate it because the radius you're getting out of an elliptical orifice is going to be smaller, and your assumptions are that the PISA is hemispheric. The pulse wave Doppler method is when you basically subtract the stroke volume you get from the LVOT from the stroke volume you get from the mitral valve annulus. A point to remember is when you're looking at an echo and you have a normal sized ventricle and the EF looks normal, and you look at your LVOT stroke volume and it's slower than what you would expect, this should raise a suspicion that there's significant MR, because your LV stroke volume has only two paths to be able to go, either the LVOT or through the mitral annulus as MR. So if the EF looks good and the LV size is decent, is good, then any decrease in your LVOT, assuming that you've measured your LVOT diameter correctly and traced your pulse wave Doppler, that should raise suspicion that there's significant MR. So whenever you see a low LVOT stroke volume, kind of pause, look back, and look for any hidden MR. So the limitations of this method is that you cannot use it in combined MR and AR, and this is one of the strengths of MRI actually when you have combined regurgitant lesions. Your annulus is assumed to be circular, and again, small errors in measurement can lead to substantial errors in MR's severity evaluation. The volumetric method kind of mirrors what's done in MRI, and that's when you subtract your LVOT stroke volume from your biplane stroke volume. Because again, anything that's going to be ejected by your left ventricle, if it's not going through your LVOT, it's going through your mitral valve. Limitations is sometimes you don't have good apical views, you have foreshortening, you're not unable to see the apex, and sometimes you need to use contrast to make sure that your volumetric assessment is accurate. So in addition to the quantitative methods, again, you want to make sure that you're using your the timing of MR jet as you're thinking about the severity of mitral regurgitation. For example, this is a late systolic jet resulting from mitral valve prolapse. So if you're just looking at the color in one frame, this looks, significant, maybe moderate to severe. But when you look at the continuous wave Doppler, you realize that this is a mid to late systolic mitral regurgitation. So when you don't have a holosystolic MR jet, you never want to rely on one frame. So if we take this example of this late systolic MR, if you're getting your PISA and just looking at your EROA, then you're going to measure your PISA radius, and that's going to give you an EROA that's more consistent with moderate MR because you're relying on one frame. PISA at this point gives you an EROA in the moderate range. But then whenever you have non-holosystolic MR, you always want to go a step further and calculate your regurgitant volume because MR is only happening in part of the cardiac cycle. So you can't assume that PISA is happening throughout systole. So in these cases, make sure you measure your regurgitant volume by multiplying your EROA by your TVI, which is going to be half of the cardiac cycle, and then you'll get MR in the mild range. So again, non-holosystolic MR, don't rely on a single frame measurement, either color, vena contracta, or EROA. You want to make sure you try to calculate your regurgitant volume. And timing is everything, like everything in life. And don't forget diastolic MR. It's less commonly encountered, but occurs when your LV-EDP is more than your LAP, leading to reversal in the gradient across the mitral valve. You see this in high-grade AV blocks and in patients with significant aortic regurgitation or any case where you have high LVEDP. And I can't emphasize how important this figure is. It's a bit, it's busy, but it's a good kind of reference for you when you're looking at mitral regurgitation. Sometimes the MR is clearly mild, and sometimes it's clearly severe, and those are the straightforward cases, but a lot of times it's kind of in between, and that's why you want to make sure you try to quantify your MR severity. There are specific criteria for mild MR, which is small narrow jet, a vena contracta of 0.3 or less, when your piezo radius is absent or less than 0.3 centimeters, when you have an A wave dominant inflow, or where you have a soft or incomplete jet by continuous wave Doppler, and when your LV and LA sizes are normal. Sometimes it's clearly severe when you have a flail leaflet, even though there was recent studies suggesting otherwise, but for the most part, flail leaflets can lead to significant MR, vena contracta of 0.7 centimeters or more, when your piezo radius is more than 1. And I want to stop here and say, whenever you're reading an echo and you don't see the jet in the LA, but there's a huge area of low convergence, what happens proximal in the valve is sometimes more important than what's happening in the LA, because a lot of things can affect your color Doppler in the left atrium. So anytime you're seeing a sizable area of low convergence, have high suspicion that you're dealing with significant MR, and make sure you quantify it. If you have a central jet more than 50% of the LA, that's another specific criteria for severe MR, particularly primary, and when you have systolic flow reversal in your pulmonary veins. If you don't meet 4 of these criteria, then you're going to have to go do some quantitation. And when your EROA is 0.4 centimeters or more, your regurgitant volume is 60 cc's or more, or a fraction of 50% or more, those are consistent with severe MR. And again, the art is choosing which method to choose in which study, and that's why the evaluation of MR is more complex than, for example, aortic stenosis. So make sure you look at all the different views, assume there's MR, and prove to yourself that there isn't significant MR, and choose the right quantitation method for the right study. There are special considerations in functional mitral regurgitation, because some of these specific criteria do not necessarily apply to patients with functional MR. So your mitral regurgitation volume is going to be lower in patients with functional MR because it's a low flow state. So you're not expected to see a lot of 60, 70 cc's regurgitant volumes. The EROA in functional MR is frequently elliptical or crescent-shaped rather than hemispheric, as we saw in that previous 3D image. And this can lead to underestimation of MR by your piezo method. So make sure you use other methods and incorporate all the different findings. Functional MR has a biphasic pattern in systole, where it peaks in early and late systole in response to dynamic changes in the transmitral pressure. And as we know, the timing of MR and the fact that the piezo is coinciding with your Vmax might affect your evaluation. And then parameters such as LV size and function, your LA size, the E to A ratios, the pulmonary venous pattern, and the PA systolic pressure are frequently, can be caused by the underlying cardiomyopathy or elevated filling pressure, so they're less specific when you're dealing with functional MR as compared to primary MR. And after you've determined the mechanism, the severity, then you want to look for the consequences of MR. Has this significant MR led to any LA enlargement, LV enlargement, LV systolic dysfunction, or pulmonary hypertension? And again, this is a case where you have a flail posterior leaflet, and you can clearly see that there's LV dilation and systolic dysfunction. Your LA is big, your RV is depressed, and that patient had pulmonary hypertension as well. So all these are things that you need to make sure are in the report when you're evaluating mitral regurgitation. And if you see color and you're unable to assess it, but again, you see that you have these consequences, go back and reconfirm the severity of MR. Management of primary MR. Anytime you have severe symptomatic valve lesions, that's usually a class 1 indication for intervention. When you have asymptomatic severe MR, then you would intervene if your EF is less than 60% or your LVN systolic diameter is 4 centimeters or more, or there's progressive increase in LV size or decrease in EF. So when you're serially evaluating someone and you're leading echoes on somebody with significant MR, look back at the previous study, compare the LV sizes, and make that comment, because it can affect management. Secondary MR, the most important step in the management is making sure that the patient is on guideline-directed medical therapy by heart failure specialists. Make sure that they've had resynchronization if they're candidates, and then you would consider edge-to-edge repair if you have favorable mitral valve anatomy, if your EF is between 20 to 50%, if your end systolic diameter is less than 7 centimeter, and if your P systolic pressure is less than 70. So again, these things need to be in the report because again, there are certain specific criteria based on clinical trials that show where TEER can be beneficial for patients with functional MR. And we'll talk about this more in June. There's going to be a lecture dedicated to transcatheter edge-to-edge repair. But just to kind of underscore the importance of the MR evaluation when you're seeing these patients with functional MR. So there are 2 trials that were published, which were the MITRA-FR and the COAPT, both looking at TEER in medically optimized patients with significant mitral regurgitation. MITRA-FR did not show any benefit versus the COAPT that showed significant reduction in hospitalizations for heart failure and actually had a mortality benefit in patients who underwent TEER. And some of the key differences in these populations were related to the inclusion criteria related to the severity of MR and actually the actual patient cohort that were enrolled. So for the MITRA-FR, which was the negative trial, severe functional MR was defined as an EROA more than 20 millimeters squared or regurgitant volume more than 30 versus the COAPT, which used kind of a higher EROA and regurgitation fraction, regurgitation volume cutoffs of 30 millimeters squared or 45 cc's per beat. The actual population in the MITRA-FR had an EROA of 0.31 versus 0.41 in the COAPT trial. The LV end diastolic volume was larger in the MITRA-FR at 135 cc's versus 101 cc's in the COAPT trial. So evaluating your LV size when you're reading an echo, measuring the volume if you have good endocardial definition, and then quantifying the MR again can have consequences on the management of the patient. So echo first in mitral regurgitation, but when do we use MRI? You can use it when you have multiple MR jets and it's hard to quantify. Eccentric jets that are challenging to evaluate by echo. When you have discrepancy with the clinical findings, your patient is symptomatic, but your echo is showing moderate MR, and you suspect that the symptoms might be related to the regurgitation, then you would get additional imaging with an MRI or TE. When you're interested in quantification of the cardiac size and function, if you want to evaluate LV scar, because that can have prognostic implications on patients with mitral regurgitation. And finally, when you have multivalvular disease, when you have AI, MR, TR, everything is leaking, MRI is your best friend. So take-home points is make sure you always define the mechanism, determine the severity, comment on the consequences, and make sure to use TE and MRI when the mechanism or severity are indeterminate by TTE or there's discrepancy with the clinical presentation. And the last point is, again, assume there's significant MR. When you're reading an echo, look at your LVOT stroke volume, look at the chamber sizes. Make sure that you prove to yourself that there's no significant MR because this is a disease that can hide really, really well. Thank you. Right?
Now the real stuff. All right, I'm going to complete this talk by talking about MRI. So continue from where Dr. Faza ended. My only disclosure is that my heart is an echo, my brain is an MRI on this subject. This is the outline of my talk. We're going to talk about indications, essentially the last slide that Dr. Faza showed, then mitral regurgitation, quantification, mechanism, consequences. How do we grade echo? We're going to how do we grade MRI on echo and MR, on CMR? Some nuances about this, and then finally one slide about the strengths and weaknesses. So we usually order MRI when the image quality is not good, when there's some discordance between the echo Doppler volumetric measurements, when you see something on echo but the patient is symptomatic, you're not very sure, or in case you have multiple lesions, essentially mostly when you have MRAR. So you want to assess each lesion, how much is contributing to the regurgitation, and then which one you want to target first. So lesion quantification. What do the guidelines say? ACC, AHA guidelines, ASE, they both agree on the cutoffs for severe MR, irrespective of the etiology. However, the general rule of thumb is the following. If you have primary mitral regurgitation, put more weight on regurgitant volume versus fraction, because if there's a kind of a race between volume and fraction, there's the more likelihood that the patient will get to the volume cutoff before getting to the fraction cutoff of severe in primary MR, because the ventricular function is maintained, stroke volume is high in the denominator. On the flip side, in secondary MR, the ventricle is struggling to give a large volume. So it's very difficult for the ventricle to get even to the 60 milliliters in the setting of low flow secondary MR, because you can have low secondary MR that's not low flow. So there's more likelihood that the patient will get to the 50% before, if ever, getting to the 60 milliliters. So these are the general rule of thumb. So how does MRI quantify mitral regurgitation? I'm going to list the three main formulas. This is the workhorse of MRI, essentially. It's a volumetric formula. It doesn't care about the mechanism, how many lesions, eccentricity, whatever. It's just pure volumetric. We trace the ventricle, we get the total stroke volume, and then we subtract the aortic flow from that. And this applies, we talked about this many times, even in the absence of aortic regurgitation, right? If you don't have a good aortic forward flow because of some subaortic membrane, mitral valve SAM, we can use the net pulmonary flow on the other side as a surrogate for that. Usually they're very similar, and apply the same formula essentially. If we don't have flow for whatever reason, and then mitral regurgitation is the only lesion that we see or we know it exists, we can just subtract the volume. So LV stroke volume minus RV stroke volume, right? The difference should be approximately the mitral regurgitation. So usually we rarely use the second and third methods. It's mainly the first. And then when we calculate the regurgitant fraction, we divide the regurgitant volume over the total LV stroke volume. However, if there's aortic regurgitation, we need to subtract it to reflect only the volume that's crossing the mitral annulus, right? So how do we calculate the total LV stroke volume? It is the Simpson method. So on echo, we use the modified Simpson. On MRI, we use the Simpson. So we slice essentially on discs the ventricle from top to bottom, and then we trace each one. We know what the slice thickness is, and then we multiply the slice thickness by the area. We get the volume for each slice. We add them together in end diastole, and diastole, and systole. We subtract. We get the total stroke volume. When it comes to how much is leaving the ventricle into the aorta, we prescribe a plane of flow. We call it phase contrast in the proximal ascending aorta, and we calculate that flow as you can see here. And then the difference between those two, essentially in this case, we have 144 for the total, 90 for the forward. We subtract those two, and then we get the volume, and then we get the fraction. It's as simple as that. If we don't have, this is just an example, if we don't have the aortic, we can apply the same for the PA flow. As you can see here, we prescribe a phase contrast plane in the proximal and the main PA, and then we can calculate the flow there. So there are other ways to directly measure or assess the mitral regurgitation on MRI, which is by looking specifically at the orifice area. These are studied, but we don't use them. And these work more, and if you think about it, in more flat orifice areas like central and secondary MR, because if you can imagine if there's flail or prolapse where like the orifice is tilted, it's difficult to achieve this image. But anyway, this has been studied, and then if you have an atomic orifice area more than 0.4, it's highly associated with significant mitral regurgitation. Again, we don't use this, but it's there for you to know about it. So next, about lesion mechanism. So generally, we divide mitral regurgitation, as Dr. Faza said, into primary and secondary MR. And I'm going to talk about or show examples of each one, but I want you to know something now. With the more advancement of catheter therapies, we're realizing that this division is kind of crude between primary and secondary, because within secondary, like although we call it secondary because the valve itself is not, it's normal, quote unquote, but there are different geometrical disruptions of the leaflets based on what's causing that. So some of those are labeled as secondary, but in a way they're behaving like primary. And I will show you later how these are mostly the population of the coapt as opposed to the mitral FR. So just, I think going forward, we need to be more detailed when we report the mechanism to not just say secondary. Specifically in primary is easy. In secondary, to try to say why, is it just annular dilation? Is it the posterior leaflet is tethered? Like what kind of secondary, because it can be important. So within the primary, the number one pathology is essentially when we say prolapse or flail. However, these can occur in different pathologies. We have the more younger population, which are the myxomatous degeneration, where we have excess tissue in the leaflets causing prolapse, bileaflet prolapse, eventually flail. And we have the older population, we have loss of tissue, which is called fibroelastic deficiency. These are elderly people that present with, let's say, focal flail of the posterior leaflet, whereas you don't see much thickening in the leaflets, there's no prolapse, and just like isolated one segment lesion, essentially. So this is for the more common primary. How do we localize the lesion on MRI? Yes, we can do it the same way almost we do it on TEE 3D. This is just a view here, for example, of a P2 prolapse. So on this view here, although it's flipped, so anterior is up, P1, A1 are up, and P3 are down. But you can, for the, I think, trained eye with good experience, you can tell more or less where the lesion is. However, we also have the tools of slicing that annulus from medial to lateral. This is only showing 3, but we usually even do more in between those 3 to kind of delineate exactly where the lesion is. And in this particular example, you can see on the right side how we can, slice at the location of the lesion, which happens to be an A3 scallop flail. This has been tested against TEE using surgery as a reference, and the accuracy of MRI is pretty good. However, if you notice, the sensitivity is low. Why? Because sometimes MRI can miss a flail segment, because flail is a rapidly moving, irregularly moving structure that can be missed on MRI. MRI doesn't like irregular moving structure. So in terms of specificity, when we see it, we know it's there, but sometimes we miss it. Few examples, other examples of primary calcified mitral valve. You can tell easily here on the image that calcium, this is MAC. Calcium is essentially dark black, no signal on MRI, but you can tell this is calcific MR. This is rheumatic. The hockey stick is added. It's not part of the MRI. So, but this is, you can see how the anterior leaflet is behaving. You can see the posterior leaflet is fixed. This is a beautiful, I think, ischemic secondary MR, right? So this is kind of different than the just dilated annulus. And you can tell on MRI nicely how we have this large infarct, and the posterior leaflet is essentially just vertically fixed, right? And the anterior leaflet trying to get to it, cannot get to it, and then you have this eccentric jet. Some people used to call this on echo relative anterior prolapse of, but this is not prolapse. None of the leaflets is crossing the annulus. This is secondary MR. This is of non-ischemic origin. This is probably represents more the mitral FR population, if you will. This is just symmetrical dilation of the ventricle, tethering of the symmetrical tethering of the leaflets, and because of that, there's malcoaptate. The leaflets cannot, they didn't adapt by growing. Sometimes they can grow and adapt and close that gap, but if they can't, you have this annular dilation and the central malcoaptation in the MR. Few words, few words about atrial secondary MR. Now you're hearing about it more and more. This is something you have to think about. Mostly you're going to see it probably in atrial fibrillation. Clinically, it has been associated with HFpEF, elderly, anything that essentially enlarges the left atrium. There has been a document from JACC imaging about like defining it and the characteristics of atria, although we don't really quite understand fully the mechanism. But essentially, whenever you see an LV that's normal function, normal size, and no particular pathology in the leaflets, but you have significantly dilated left atrium, this is when you should think about it. In those cases, restoring sinus rhythm in the case of AFib can help reduce the MR. Most of those patients are old, so they're not usually good candidates for surgery. M-tier, clip has been tried, and there has been high procedure success and improvement in symptoms, and higher survival rates compared to ventricular secondary MR, however, worse than primary MR. Other, quickly, a few images about miscellaneous, if you will, mechanisms of MR that you can identify on MRI. This is SAM with posteriorly directed mitral regurgitation. This is endocarditis. I don't know why it's pixelated, but this is endocarditis with a posterior leaflet perforation, right? And this is a cleft, like the anterior cleft, like the case that Dr. Faza showed. You can see very nicely how the anterior leaflet, there's this big cleft there where the regurgitation is originating. Next, I'm going to talk about lesion consequences. So We know that mitral regurgitation can lead to, progressive dilation of the ventricle and the atrium, and I already made the case that MRI is very good at, assessing those, and obviously the LVEF. However, one particular tool for MRI that is unique to MRI is ECV measurement, and that has been studied as a kind of a surrogate of those people who have significant mitral regurgitation, they're asymptomatic, and kind of maybe the ventricle has started to be affected, microscopically, if you will, where there is interstitial fibrosis reflected by ECV. So in this particular study from here, people with the same regurgitant fraction more than 40%, those who have a high ECV, meaning have high burden of fibrosis, although they are asymptomatic, they were more likely to develop symptoms and undergo mitral valve intervention down the line. So that's unique to, maybe we should start reporting it more, I think, in MRI. We haven't been using it clinically more, but just so you know that it exists and that sometimes can be used as a tiebreaker. I'm going to talk briefly here again about proportionate and disproportionate secondary mitral regurgitation, again from the lens of the COAPT and MITRA-FR. As I said, in COAPT, the population of COAPT was it's kind of primary and a half, if you will, mitral regurgitation. It's not pure second. There is something, although it's labeled secondary, but there is some distortion of the leaflets that makes it in a way primary, right? It's not that the leaflets have something that started there. It started in the ventricle, for example, but has affected the geometry. It's behaving like a primary, right? So those people are, respond less to GDMT and respond better to TEER. And there was a recent review in JACC Imaging about this whole concept, about secondary MR in general, from the lens of, again, MTEER, but talking a lot about proportionate and disproportionate MR. And if you just look at this kind of a graph here, they kind of nicely showed multiple zones of proportionate, disproportionate MR. And then you can see, for example, whenever you have disproportionate severe mitral regurgitation, how the EROA is relatively higher than the EDV. The EDV is still, enlarged, but the EROA is significantly high. And then with proportionate, they're both enlarged, but like kind of in a way symmetrically. So how do you reflect that in terms of measurements? In echo, you can do a ratio of EROA over LV-EDV. And Dr. Faza showed a table, if you notice, like both groups, where the EROA was higher in COAPT, the LV-EDV was lower. And on the flip side, in MITRA-FR, the EROA was lower, EDV was higher, meaning the ratio was significantly higher. On MRI, even before COAPT on MITRA-FR, there was a study in 2018 doing regurgitant volume, as a surrogate of EROA over EDV, and they showed that in primary MR, the regurgitant volume ratio of EDV is almost 30%, whereas in secondary MR is 12%. Okay, when they did the COAPT and MITRA-FR, the ratio for COAPT was 0.31, very similar to primary, whereas for MITRA-FR is 0.18. This is again showing that the COAPT population is more behaving like a primary MR pathology. And it's important when we're reading, I think, those studies to look at least, for the EROA over EDV ratio or regurgitant volume over EDV ratio to kind of get a feel, will this patient respond to the catheter therapy as opposed to just GDMT. Another aspect that MRI can identify is the known mitral valve prolapse-related fibrosis. This is here I put this cartoon here to kind of show you how the mechanism starts. So it starts obviously with the prolapsing leaflets, and then you have this paradoxical motion of the papillary muscles. Normally the papillary muscles should go down, right, apically during systole. Here they're paradoxically going towards the base, and there's this traction at the papillary muscles, traction at the muscle and the basal and ferolateral. And we know there is scar formation that we can detect in MRI, and that has been studied from this institution, showing it tracks the significance of the mitral regurgitation. And we know from other studies that is associated with arrhythmias, whether it's PVCs or VTAC, VFib. So what about comparison of MRI and echo in terms of mitral regurgitation grading? So I'm going to show a couple of studies about this. So the one from 2015 from Uretsky et al., they used MRI, the same volumetric method, and then in terms of echo they used PISA, and their kind of gold standard of which method is more accurate is the remodeling after surgical repair of the valve. So kind of they did the delta EDV remodeling, as the kind of you see it on the y-axis here, and then what kind of regurgitant volume pre-repair predicts that remodeling. Meaning, if you're correct on the regurgitant volume, then you should predict the remodeling accordingly. And it showed here, at least in this study, that with CMR, there's a good correlation between preoperative regurgitant volume and postoperative remodeling, whereas on echo using PISA, that relationship was not there. Another study, also an important study in this field, is from Europe. And in this one, they did TTE, TEE, and MRI all within 24 hours. The TEE was used to calculate the vena contracta width, the PISA, all these parameters, and the echo was used to calculate the other Doppler parameters and the ventricular volumes, and obviously with the MRI. And these were all moderate and severe asymptomatic patients. And the way they calculated or they graded the mitral regurgitation on echo is the ASE guidelines. So they use the ASE integrative approach. If you have, let's say, 4 parameters or more, that's severe. If you have less than 4, they did an average of PISA and mitral. So they calculated PISA, they calculated the mitral inflow, they averaged the volumes, and that volume was used to say if this is moderate and severe. And the concordance was good, 76%. The discordance between grading was 24%, and discordance was mostly found in late systolic jets, multiple jets, and eccentric jets, which are the ones that we struggle with, and which are the ones that, if you think about it, that PISA struggled with, right? So kind of more of a argument here for try to use more of the volumetric method. I think whenever, especially when you see those cases, use the volumetric method when you're reading the echo to quantify mitral regurgitation. In this particular study, they used outcomes or survival, as a metric to assess the MRI and echo grading, and then from this only essentially the red lines are the ones that were called severe by MRI. The black ones are the ones that are called non-severe by MRI, and then echo was not correlated with that. So essentially, it's showing that MRI was driving the outcomes in this study. Finally, one last thing about the prolapse volume. Just I'm mentioning this as possibly as a reason for why there could be some discrepancies between echo, specifically if you use PISA and MRI, because in this prolapse volume, whenever you're dealing with Barlow situations, you're mostly dealing with the jets that's crossing the leaflets. Whereas if you employ the volumetric method that MRI does, it's calculating both together, adding the prolapse volume and the MR. That could explain some of the discrepancies at least. But I'm putting it there so you are at least aware of that when you're trying to quantify in the lab. All right, and final slide is about strengths and limitations. So the strengths of MRI is, no limitations of acoustic windows or body habitus. Anyone can go in the scanner, as long as they can hold their breath enough. Free choice of imaging planes, high signal to noise ratio, accurate and reproducible measures of cardiac size and remodeling. We can do viability and scarring. We can quantify accurately the flows. And severity assessment is based on just volume and fraction without any assumptions. Limitations, again, it's not widely available. Claustrophobia cannot be performed at bedside. Implanted devices and CKD are no longer an issue from a scanning standpoint, but implanted device can affect the image quality, of course. Breath holding, as I said, can be an issue. Arrhythmias, but it's challenging for everyone. Again, can't see the mechanism if it's like an irregularly moving structure such as flail or small vegetation. Flow turbulence can affect the flows, and the outcome data based on MRI is still limited, right? Because it's relatively new, but it's growing. All right, and that's it for me. Thank you. Dr. Faza, you want to join for echo questions?
Okay, first off, really very nice job. I think you guys did a very nice balanced approach. I want to probe you a little bit further with regard to this AFib. People always talk about that. Maybe tell me from the echo side how you approach it. And is all AFib can't be done, or some AFib? And then Carlos, from the MRI side, how you approach it.
AFib is challenging because you have beat-to-beat variability, and ideally you want an average box disease to look at it comes to different RR intervals and kind of have an idea about how severe it is. Again, if you're relying on any method, you're asking if you're electric or not, then you're actually choosing your cardiac cycle to do your measure average range, or looking for these other indirect signs that the MR ECG is picking up. But it is challenging.
So the way I see it in atrial fibrillation, obviously, is that there's no fixed anything in atrial fibrillation from beat to beat. No EF is not fixed. Forward flow is not fixed. Obviously, regurgitation is not fixed. It can go between 60 on one beat and 30 on the next beat. So, but from the nature of MRI, the way we acquire those cases in atrial fibrillation is that we kind of the way we set the imaging is we select a certain RR interval that the patient is mostly in between, and then we measure those flows essentially. And by nature of how we do it, we're kind of reflecting more the average regurgitant volume in a way, because those beats that are short RR with a regurgitation of 30, and those with a very long RR with a regurgitation of 60 are kind of deleted, if you will. And then we kind of probably doing and I would say that on echo, that's what we should do, especially, let's say, in PISA, it's going to be challenging, but if you're doing volumetric, I think we should, average many LVOT TVIs, and then maybe pick an LV, even you can average, if you have the time and to average multiple biplane as well, if you want to really do it. But there's always a way, but the number that we'll get, it's going to be an average, which is
I
the
mean, I
reasonable
think
thing to do.
it has a wider band of variability, but I think that just AFib doesn't necessarily mean you can't try to come up with an assessment. It's just that whatever value you get, you need to recognize there's a wider range of plus minus for it.
Another question? Okay. All right. Thank you, everyone.